Hello everyone and welcome back. This is Ahmed Radwan with the USMLE Step 2 CK channel, and we are back with Pediatrics. Excuse my voice, I do have a little cold, so if my voice sounds a little bad or anything like that, please excuse me. I'll try to speak clearly as possible as I can. Alright, we are on page 365, Master of the Boards 3. And we are started with jaundice in the newborn, a very important topic. What we see here first is a diagram, and it kind of delineates or kind of summarizes what the jaundice in the newborn approach should be like. If we do have jaundice in someone who's a newborn, we either think it is a physiologic or a pathologic jaundice. Let's take physiologic first. In physiologic, it's going to be indirect. Okay, indirect hyperbilirubinemia, and what that means, it means that the liver is not really working well and not able to produce the direct the bilirubin, so the indirect is going to rise up, and we either have two things that would cause the indirect here. Either we have a negative Coombs test or a positive Coombs test, and if you think about the positive Coombs test, we do have the RH and EBO incompatibility and thalassemia minor. And the negative Coombs test is going to be a high hemoglobin and a normal or low hemoglobin types. If we have a high hemoglobin with negative Coombs test, it's going to be polycythemia, twin-to-twin transfusion, maternal-fetal transfusion, delayed cord, intrauterine growth retardation, and infant of a diabetic mother. If we have a negative Coombs test but a normal or low hemoglobin even, that means that we do have hemolysis. It's going to be either spherocytosis, leptocytosis, G6PD deficiency, and pyruvate kinase. Those are the indirect types. And when it comes to the directed types, it's going to be something that will increase the conjugated bilirubin, or something that the liver has already stored and has already processed. So what we see in these cases is going to be either sepsis, it's going to be TORCH, it's going to be TORCH infections, it's going to be total parenteral nutrition as a cause, hypothyroidism, galactosemia, tyrosinemia, cystic fibrosis, and finally cloacal cyst. And I don't think we're gonna dive into details in each specific one, but we just know those. That would help. So we either have either a pathologic or a physiologic one, and they can either be direct or indirect. Usually the physiologic is going to be indirect, but the pathologic can be direct or indirect. We talked about the indirect or the indirect. It's going to be either divided into a Coombs positive one and a negative one, and the Coombs negative one is going to be either high bilirubin or high hemoglobin, I'm sorry, and the other one can be low hemoglobin. The direct, we listed the causes of the pathologic direct hyperbilirubinemia. All right, so there is a good question here that asks, when is hyperbilirubinemia considered pathological? So it's considered pathological if it appears on the first day of life. Actually, you can look at this question as, when can it be physiological, or when can we eliminate that it is physiological? And if the hyperbilirubinemia is on the first day of life, it's pathological, because physiological starts in the second to third day of life. If bilirubin rises more than 5 milligram per deciliter per day, that means it's pathological. If the bilirubin at all is 12 milligram per deciliter in a term infant, that means it's pathological. If direct bilirubin or direct bilirubin is more than 2 milligram per deciliter at any time. And finally, if it is present after the second week of life. So the time frame here is after the first day, less than the 2 weeks of life. It could be considered physiological. If bilirubin doesn't rise more than 5 milligram per deciliter per day, and bilirubin doesn't really reach 12 milligram per deciliter in a term infant, if the direct bilirubin is not 2 milligram per deciliter at any time, this could be considered physiological. Otherwise, it is pathological. So those are the two ways to look at those conditions. On the next page, we do have a big basic science correlate. It has a diagram up top and then some information down below. In the diagram here, we do have how the bilirubin is actually made. And we do have inside of a macrophage that would eat up a red blood cell, for example. We're going to have the heme and the globin parts. They're going to be separated, and the heme part is what we care about here. The heme, we do have a bunch of enzymes that I'm going to mention that will work on it to turn it finally into bilirubin, and then we go from there to a different site and so on. So the heme first, it's going to be worked on by the heme oxygenase, which will turn it into biliverdin, and biliverdin reductase is going to work on that and going to turn it into bilirubin. So heme, biliverdin, and then bilirubin. After the bilirubin is formed, it's going to go through the bile duct, and then it's going to be it's going to be worked by the glucuronic acid. It's going to be removed by the bacteria, and the bacteria can work on it and then turn it into a stercobilinogen or yellow bilinogen and so on. And that will turn into the stercobilin, and this is going to be all in the intestine. The stercobilin is going to be reabsorbed into the enterohepatic circulation via the portal system, and then go again into the liver and so on. What is said here underneath this chart, it says that hemoglobin breaks down to bilirubin. Newborns have low levels of the glucosyl transferase. I'm very sorry for my voice. I really just have a really bad cold, but I'm gonna try to speak slowly as much as I can. So glucosyl transferase enzymes, the enzyme that connects or conjugates the unconjugated bilirubin to glucose so that it can be excreted through feces. Higher levels of unconjugated bilirubin are needed during development when it can cross the placenta and be removed from the fetus by the mother. So, in general, the newborn do not have the glucuronide transferase enzymes, and this leads to a probability of having unconjugated bilirubin a little high. So, and that's actually important for the fetus because higher levels of unconjugated bilirubin are needed during development. So, anyways, the third point is that the RBCs of newborns also have a shorter lifespan, so they break down RBCs, release unconjugated bilirubin a little more. Okay. Now we're done with the basic science correlate here, and let's look at the diagnostic testing. How are we going to test for jaundice? Well, if jaundice presents in the first 24 hours of life, we first do total and direct bilirubin, and that's a given, of course. And we do blood type of the infant and the mother. We'll look for ABO and RHM compatibility. Direct Coombs test, of course, to see if it is Coombs positive or negative. CBC, reticulocyte count, and blood smear, so we can assess for hemolysis at that point. So we actually are following the scheme that we talked about before. And then we do a urine analysis and urine culture to see if elevated the direct bilirubin, so we can assess for sepsis. If at that point there is prolonged jaundice of more than 2 weeks, and no elevation of conjugated bilirubin, we should consider that it could be a UTI or another infection. It could be bilirubin conjugation abnormality like Gilbert syndrome or Crigler-Najjar syndrome, which was very famous. It could be hemolysis at that point that is continuing and happening, and I think the Coombs test and the the retics and the CBC will give us a good result. Intrinsic red cell membrane or enzyme defects like spherocytosis, elliptocytosis, G6PD deficiency, and pyruvate kinase deficiency, and so on. Where there is a prolonged jaundice of more than 2 weeks and elevation of the conjugated bilirubin, we should consider cholestasis. And this will be the initial diagnostic test should be liver function tests and see how it goes. And the most specific test is going to be an ultrasound and a liver biopsy. So those are the two things we should consider here if we are thinking about bilirubin conjugated and more than 2 weeks. How are we going to treat that? First, the phototherapy is going to work, but this is going to be when the bilirubin is more than 12 milligram per deciliter. Normally, it would decrease by 2 milligram per deciliter every 46 hours, which is fantastic here. The second one is going to be exchange transfusion, and this is going to be in any infant with suspected bilirubin encephalopathy. And I think encephalopathy would peak from 15 to 20 milligram per deciliter. And that's when we can suspect that, but of course the clinical science is going to show that. And the second thing when we use exchange transfusion is if there is failure of phototherapy to reduce the total bilirubin and the risk of kernicterus. Okay? All right, so we have two side notes here. The first one is going to be the basic science correlate, and it says about phototherapy, what it does. The phototherapy actually isomerizes the bilirubin, and what it does, it makes it water soluble, so it can be excreted through urine. And the second note here that says that the most feared complication of jaundice results from elevated indirect or the unconjugated bilirubin. And why? Because it can cross the blood-brain barrier. That's the problem here. And later on, it deposits in the basal ganglia and the brain stem nuclei and would cause kernicterus. We should watch out in such cases for hypotonia and seizures, any delayed motor skills, and sensorineural hearing loss, and so on. Management is immediate exchange transfusion at that time if we suspect a bilirubin encephalopathy and kernicterus. All right, okay, so that has been the jaundice and newborn. Now let's move to a next step, which is the neonatal sepsis. We have here a scenario that says that a 5-week-old infant is brought into the clinic with irritability, weight loss for about 3 pounds over the past week, and grunting. Physical examination reveals temperature of 102.5 Fahrenheit, which is elevated. There is a bulging anterior fontanelle, a delayed capillary refill. What is the next step in management? And the answer is right there. It says that the next step in management includes transferring the patient to the emergency room and initiating a full sepsis workup. So that patient is in sepsis, of course, because he has a high fever and localizing sign. And the next step should be transfer him to the emergency room right away and do the full sepsis workup. What is it? It's going to be including the CBC and with differential. It's going to be blood cultures. It's going to be urine analysis and urine culture looking for the source of infection. And 4 is going to be the chest x-ray before the antibiotics are given. All of that is before the antibiotics are given. Continuing in the case of an early onset sepsis, let's say for the first 24 hours here, pneumonia is the most common cause. And the most common organisms are going to be the group B strep, the beta hemolytic gram positive, the E. coli, which is going to be gram negative, rod shaped, Haemophilus influenza, which is going to be the Coccobacilli, gram negative, and Listeria monocytogenes, the gram positive, motile with flagella. So early sepsis, pneumonia, and the most common organisms, the group B strep, the E. coli, H. influenza, and Listeria monocytogenes. If we are thinking about in a case of late onset sepsis, let's say after the first 24 hours, we should think about meningitis and bacteremia as the most common causes here. The most common organisms is going to be the Staph aureus, which is the gram-positive cocci, the E. coli again, Klebsiella, it's going to be the gram-negative oxidase-negative rod, and the Pseudomonas, which are gram-negative aerobic bacteria. So again, Early onset, pneumonia, gram-B strep, E. coli, H. influenza, and Listeria monocytogenes. Late onset, more than 24 hours, it's going to be meningitis and bacteremia. It's going to be caused by Staph aureus, E. coli, Klebsiella, and pneumonia, and Pseudomonas. I'm sorry. Okay, moving from that, we do have a basic science correlate here, and it says here that gram-positive bacteria stain purple due to the thick peptidoglycan layer, and the gram-negative bacteria, they stain red due to the thin peptidoglycan layer. And we do have here a diagram for both. You can take a look at it and see for yourself. Okay, so and the after we are done diagnosing that patient, how we're going to treat? What we're going to do is empiric treatment of neonatal sepsis, and that's going to be by prescription of the ampicillin and gentamicin, and that's going to cover the gram-positive and the gram-negatives here until 48 to 72 hours of the cultures are negative. Of course, we draw the cultures before we give the antibiotics here for accuracy. And if it is meningitis, or we suspect that it could be, we could add the cefotaxime. So again, ampicillin and gentamicin, and until the results of the culture. And if we suspect meningitis, we do add the cefotaxime. Okay. Now we're done with that, let's talk about the torch infection here. Torch is a summary for, or a mnemonic for the toxoplasmosis, rubella, cytomegalovirus, herpes, syphilis, and varicella. And those are not really read into that, but the T is for the toxoplasmosis, of course, the R is for rubella, the C is for cytomegalovirus, the H is for syphilis, for herpes, and torches, the add the S sometimes, the syphilis, and so on, the varicella. It says here that many of the torch infections have similar presentations, actually, and we do have a table here that highlights the distinguishing features to look for in an exam. And we're going to have some more onto that, into obstetrics, but let's just take a look here and see what we're looking for. We have the classic features, we have a diagnostic workup that can help us, and we do have the infection itself. So it says here for the infection as general features, we're going to have intrauterine growth retardation. We're going to have hepatosplenomegaly, we're going to have jaundice, and mental retardation. Those is going to be in most of these diseases, or even all of them. And to do a diagnostic workup, we're going to see an elevated total cold blood IgM. So the blood IgM is going to be high in the cord, and the in each of every single disease here. Okay, all right. Now let's take each one and see what we're working with. The toxoplasmosis is going to be famous for the hydrocephalus or hydrocephalus with generalized intracranial calcification and chorioretinitis. So we see here three things. The hydrocephalus, we're going to see generalized intracranial calcifications, and we're going to have chorioretinitis. So those are the three things. What we're going to diagnose it with is the IgM against toxoplasmosis, of course. The second thing is going to be rubella. Rubella is famous for the deafness, the cataracts, and the heart defects. We can see a blueberry muffin spots, which are extramedullary hemoptysis, hematopoiesis, I'm sorry. So the things to focus on is the cataract, the deafness, the heart defects. Cataract, deafness, and heart defects, and then we can see the blueberry muffin spots, which are extramedullary hematopoiesis. How to diagnose it? What we do is to do maternal rubella immune status. If it is negative, if it's unknown, we do an IgM against the rubella. So that's very important. Now moving on to the cytomegalovirus, what we're going to see is microcephaly with periventricular calcifications. What we said in the calcifications before is a toxoplasmosis, and it says we have the generalized intracranial calcifications, but here that's going to be periventricular calcifications with microcephaly. We're also going to see petechiae with the thrombocytopenia, and we can have sensory hearing loss. We also said deafness or in the rubella. So we can correlate these. So how are we going to diagnose the cytomegalovirus? It says here urine or saliva cytomegalovirus culture. If they are negative, we exclude the cytomegalovirus right away. We can do serum cytomegalovirus IgM antibodies in a newborn. That would suggest a congenital cytomegalovirus. So an IgM in a newborn, cytomegalovirus, congenital cytomegalovirus here. Okay, now let's move to the next. It says here herpes. Herpes, in the first week, we could have pneumonia or shock. In the second week, we're going to see some skin vesicles. We can see keratoconjunctivitis. In the third to fourth week, we can have acute meningoencephalitis. Very dangerous. The best initial test to do here is a Zank smear. We can do a culture, but it does not exclude the disease if they are negative. The most specific test, however, is the PCR. So, herpes virus, PCR. Okay. Next here is the syphilis. We're going to have the osteochondritis and periosteitis. We can have the squamation of the skin and rash of the palms and the soles. And finally, snuffles, which are the mucopurulent rhinitis. The best initial test here is the VDRL screening, and the most specific, of course, is the IgM FTA antibodies. So again, syphilis is going to be osteochondritis and periosteitis, desquamation of the skin, and rash of the palms and sole, snuffles, which are the mucopurulent rhinitis. Finally, we have varicella here, and it's going to be pneumonia in a neonate. If it's a congenital disease, we can have limp hypoplasia. We can have cutaneous scars, seizures, and mental retardation. What we should do as a best initial test is IgM serology, and the most specific one is going to be the PCR of the amniotic fluid. So this is the only one that we talked about, the amniotic fluid here. So the most specific test for varicella, PCR of the amniotic fluid. Okay. I'm not going to repeat this table here because we're going to take a look again at it when we talk about obstetrics in detail and more details, of course. So just take a look, try to familiarize yourself with it, and we can move on. Okay. Now let's talk about seizures here. We have a scenario here that it says in the newborn intensive care unit, an infant is noted to be jittery and has repetitive sucking movements, tongue thrusting, and brief apneic spells. Blood counts and chemistries are within normal limits. What is the initial workup of this patient? The answer here, it says that seizures classically present with subtle repetitive movement, such as chewing, tongue thrusting, apnea, staring, blinking, or desaturations. Classic tonic-clonic movements are actually uncommon. We look for ocular deviation and failure of gentleness to subside with a stimulus, like passive movement with limp. Complete diagnostic workup for seizure is listed as follows here. First, we do an EEG, which may be normal actually. We do a CBC, electrolytes, calcium, magnesium, and glucose. And because hypoglycemia can be a common cause of seizures in an infant of diabetic mother, of course. We do an amino acid assay and urine organic acids, and this is to detect inborn errors of metabolism and pyridoxine deficiency. We also look for infections that will cause that. We do the torch infection studies, total cord, the blood IgM is good for screening, like we talked before. We can do blood and urine cultures, of course. We can do a lumbar puncture if we suspected that there is meningitis. And finally, we can do an ultrasound of the head in preterms. Okay, so the only thing we do in preterms extra is the ultrasound of the head, and this is to look for intraventricular hemorrhage. Intracranial hemorrhage would cause seizure, of course, typically 2 to 7 days after birth. Okay, so we do have the blood tests here, which are the CBC, electrolytes, calcium, magnesium, and glucose. We do have an EEG, amino acid. Don't forget about that, amino acid assays and urine organic acids, torch infections and infections in general, and the ultrasound of the head in preterms. How are we going to treat such a case? Of course, we should tackle the underlying cause here, and this is going to be including the electrolyte abnormalities. For acute seizure, we do use lorazepam or diazepam, and this is going to be rectally. Okay, that's going to be different. So rectal, and it's not parenteral. The treatment for chronic seizures, that's going to be depending on the type. Either it's the absent seizure or grand mal seizures and so on. But it says here, I don't know why specifically they talked about the absent seizure, but with absent seizures, you use the ethosuximide. Okay. We do have a basic science correlate here, and it's talking about the benzodiazepine. And the benzodiazepines, they bind the alpha-1 receptor site of the GABA receptor. And that's what we talked about, the lorazepam and diazepam. And we have a diagram here, and it has the alpha-1 and the beta-2. Sorry. And the alpha-1, it has a benzodiazepine site, and it has also the GABA site. So it binds to the alpha-1 of the GABA receptor. Okay. Now we're done with the seizures. Let's take a look at the substance abuse and neonatal withdrawals here. So, in neonatal withdrawal, withdrawing of substance, it's going to present with hyperactivity, irritability. It's going to be fever, diarrhea, tremors and jitteriness, high-pitched crying, sneezing, restlessness, vomiting, nasal stuffiness, poor feeding, seizures, and tachypnea. So a host of symptoms here. The timing of withdrawal here is going to be different depending on the substance. If we do have heroin, cocaine, amphetamine, and alcohol withdrawal, that's going to be in the first 48 hours of life. If we have methadone withdrawal, that's going to be in the 9th hour. So it's going to be 4 days, up to 2 weeks even. This drug is associated with a higher risk of seizures actually as well. So if we see seizures past 4 days and up to 2 weeks, think of methadone, heroin, and cocaine, and amphetamine, and alcohol. It's going to be the first 48 hours of life. What are the complications that we should be thinking about? The complications is going to be infants of addicted mothers. They are at higher risk of the following complications here. We have low birth weight, UGR, congenital anomalies like alcohol and cocaine, the sudden infant death syndrome. So those are really important complications and very fearful ones as well. We also should watch out for complications of the mother's condition, such as sexually transmitted disease like AIDS and herpes and so on, toxemia, a breech presentation, abruption, intraventricular hemorrhage due to the cocaine use. Okay. In the treatment department here, it says that the best initial treatment is to prescribe opioids, actually, especially if a specific prenatal opioid was also known. And along with that, we use phenobarbital. A side note here says that we should never give naloxone to an infant born from mother with no narcotic use. It may precipitate sudden withdrawal, including the seizures. So never give naloxone to an infant born to a mother who is known to have substance abuse, or especially opioids and narcotics. Okay, so the treatment again is okay. Now we're done with this part here. I think we're going to stop at that at the substance abuse here, and next we're gonna see a bunch of tables. They are really important ones, and it's gonna talk about the teratogenicities and the effects on the newborn and the genetic diseases that we can see, and the conditions such as the Down syndrome and so on, and then we're gonna move on to the growth and nutrition and development. So that's been a good session. Let's pause for a little bit and we'll get back soon. All right, take care. Bye bye.